Good afternoon, everybody. Welcome to the SGH Sing Health Duke NUS Vascular Center Public Forum. Today, we're going to be discussing varicose veins. Why do they appear and how do we treat them? Thank you to all of you for taking an interest in this topic. It is quite a common problem affecting a lot of us, our friends, our relatives, and our family. I'll be glad to talk to you a little bit more about this. Let me start by sharing the screen. Sorry, can I trouble our PLS colleagues to stop screen share? All right, I trust you can see my screen now. Apologize for the minor mishap. So today we're going to talk about varicose veins. My name is Chong Zutek. I'm from Singapore General Hospital. I'm a vascular surgeon. We treat all kinds of arterial, venous, and lymphatic disease, and varicose veins are one of the conditions that I and my team would treat. I'm currently head of the Department of Vascular Surgery. There are 8 consultants in my team. We also set up this new vascular center or vascular institute under Sing Health umbrella earlier last year, and I'm also currently running that. So a little bit about myself. I graduated from Australia, did all my training in the US, spent 12 years in the US, mostly on the East Coast, and returned to SGH in 2012, so now 10 years ago. And since then have taken on some administrative roles of running the department and the SDDC. Other than work, I enjoy other activities as shown over here. I like skiing. Obviously in Singapore now, the closest I can get is water skiing. I look forward to my tennis games in the weekends, and I try to take some photos where possible. Not very well. Okay, today's presentation will be this outline. We're going to introduce the topic of varicose veins, some of the symptoms and the causes of varicose veins. How do we diagnose varicose veins? What can be done about varicose veins? So the management and treatment options, and there are quite a few. We'll talk a little bit about prevention for varicose veins, and then the outlook prognosis of patients with varicose veins. And very importantly, we have set aside time for a Q&A session. So we'll be glad to have your questions then. You can type it into the chat group as asked for earlier. This whole session will be done by 2 p.m. Okay, so varicose veins, I think everybody has an idea of what they are. They're these twisted, enlarged veins near the surface of the skin. Some of the people refer to them as these large snakes. Some are larger than others. They're usually bluish in color. Most of the people complain of the unsightly nature of them, and they're usually in the legs. You can get them in the hands and in the arms as well. However, they are less common. So this is a condition that often is misunderstood as a cosmetic issue, but when left untreated, you can progress to a more serious condition, and it's called chronic venous insufficiency. If we look at the worldwide prevalence, it's estimated to be 20% of the general population. So 1 in 5 of us have this problem. It's 10 times more common than peripheral arterial disease, something we are quite familiar with, especially given that Singapore is engaging in this war against diabetes, and we're trying to treat diabetes and diabetic foot ulcer complications. Chronic venous insufficiency can affect people from all age groups and genders. So it's not just a male-only disease or female-only disease that most people are confused about. Without treatment, this can progress to a serious medical condition. Most of the patients with chronic venous insufficiency remain undiagnosed and untreated. If you look at the table shown over here, the prevalence by age and gender, like everything else, when we're younger, we have less medical problems. You can see in the 20 to 30 age group, the prevalence in both genders are less than 10%. As we get in the 40s, it's up to 40% in females and 20% in males. And in the 60s, it increases further. So this is a condition that can affect all age groups, but the prevalence obviously increases with age. It is true that females get it more commonly than males, especially after having children. This is a video showing the physiology of chronic venous insufficiency and the normal blood flow. Okay, I've just realized that there is a sound issue. My apologies about that. I would stop share and reshare again. We'll start again. My apologies.
Itchiness, or deep veins run between the muscles of the legs. Contractions of these muscles, when you move your legs and ankles, help to squeeze the blood back up towards your heart. Veins also have valves that prevent the blood from flowing back towards your feet. Here we show a valve and the muscles around the vein. Varicose veins are thought to develop when the valves don't close properly. Here we show a valve in a superficial leg vein. If the valves don't work properly, the blood is able to flow backwards. Blood pools in the vein. Deep veins run between the muscles of the leg vein to stretch. This is called a varicose vein. Here we show a vein that has become varicose. Here we show a varicose vein in the lower leg. Varicose veins may cause symptoms such as aching, itchiness, or swelling of the ankles.
Okay, sorry about the technical problems. So a little bit about the normal veins shown on the left-hand side with the normal valves, and the normal valves opposed. These valves are in the veins themselves. They're very thin, often just a few cell layers thick, and they are almost transparent. When the vein becomes dilated or becomes damaged, for example, due to a blood clot or DVT, the vein wall does not oppose, the valves don't oppose, and you get damaged and incorrect blood flow because of reflux. On the right, the picture shows the calf muscle pump. The calf muscle is very important in the healthy functioning of the venous system in the legs. The contraction in the muscles help push the blood up towards the heart, which is the normal direction of what blood should flow in the veins. And the valves would then stop the blood from going back downwards. A little bit about physiology. The venous pressure at the ankle. We're all familiar with taking our own blood pressure. That's the arterial blood pressure. Now we're looking at venous pressure, so a little bit different. And we're looking at the legs in the ankle region. When we're lying down, sleeping at night, the blood pressure of the veins at the ankle is very low, about 10 millimeters mercury. When we're standing, depending on how tall you are, it increases quite significantly to 90 millimeters mercury. However, the calf muscles, when we walk, decrease it to 25 to 30 millimeters mercury. And this effect on the calf and the ankle pumps takes place only after 7 steps. This is also a good time if you have been standing for a long time or sitting for a long time to just get up, stretch, and walk around. Just 7 steps would help with this. Little graph to illustrate this better. The blue is the blood pressure in the veins or the venous pressure in the various positions. For example, lying down is very low. When we're standing up, it's high, 90, like we talked about. And then when we're walking, because of the calf muscle pump, it does decrease significantly. So this is really for the normal. So it's low, it goes up when we stand still, but as we walk, we activate the calf muscles, it drops. So this is really important. That's why it's good to walk around. In a defective venous system, same pressure when we lie down, when we stand is the same. However, when you walk, because of the defective valves, it is not able to drop the pressure as much. So it only comes down a little bit. And this is a problem with prolonged venous hypertension, leading to the possible complications I will show you about. And you can see the difference here between a normal vein in blue and in this yellow, the abnormal system where the valves don't work. And the difference is about 40 millimeters mercury. This is quite bad. I know many of us stand quite a bit. A lot of people with different occupations, for example, sales staff, librarians, maybe not nowadays, food sellers. And then the worst is probably the guard at the Istana, where they stand for a long time and they cannot move. So they cannot really activate their calf muscle pump. If you look at this now, is the diagnosis for varicose vein disease, and it's usually using ultrasound. Ultrasound is a non-invasive, doesn't require radiation or contrast form of imaging. Shown in this left picture over here, this is a typical ultrasound picture. It's in black and white and sometimes a bit of color to show blood flow. It's not painful, just requires a little bit of gel, and then we need to squeeze the calf muscle below in order to do what's called a Valsalva maneuver. These are representative pictures. This is normal. So this is a normal venous assessment of the right leg. This shows that the deep veins are normal. The blood flow is normal. There is no DVT or blood clot. In the superficial vein, which is the one we're most concerned about in varicose vein disease, again, the blood flow is normal, as in the direction is upwards towards the heart. This vein is called the great saphenous vein. It's on the inside of the thigh, and that's why most of the varicose veins develop on the inside of the thigh or calf rather than on the outside. This vein here is the short saphenous vein and is less commonly affected. In the abnormal picture shown on the right side of the screen, you can see that the deep vein is normal in the top part, but the great saphenous vein is varicose, as in it's enlarged. So normal size of the vein is about 3 millimeters. This is 15 millimeters, several times enlarged. The blood flow direction is also wrong. There's reflux. And so this patient would have severe varicose vein disease. These are some of the complaints that patients can have when they have chronic venous insufficiency. So varicose veins are what they can see and is what they sometimes complain about. They can get ankle or leg swelling. Most of the time they complain of leg heaviness and fatigue, worse at the end of the day, wanting to put the legs up, and only putting the legs up will it solve the problem. They might also get aches or cramps. They might also get itching of the skin, sometimes even a burning sensation. Restless leg syndrome could occur. Skin changes, we're going to talk more about it with some pictures in a few slides. And the last thing, which is ulcers, are what we're trying to prevent, these open wounds. So this is a classification of the venous insufficiency. It's called the CEAP classification, and we're going to focus on the C. So as we start below, we have C0 is normal, C1 are spider veins, and then we go upwards towards ulcers. C6 is the worst. This is from the Bond vein study. It's a study of the population to see that where most of the people have problems. So C0 is their normal, asymptomatic, about 10% of the patients. C1 are spider veins. Most of the people have this problem. I think if you look hard enough at your legs, you might see a few of these. They are usually not going to cause you a problem. They're more of a cosmetic issue. C2 are varicose veins. You can see these are very large varicose veins. Ours are not so big, but with time they can enlarge and develop into these large sizes. C3 is where you have swelling or edema, and you can see here, if you push your finger down on the calf area of this patient, it leaves a mark. So this is swelling. And if you look at the ankle region, it's easy to tell which ankle is swollen and which is not. C4, there are two slides I'm going to show you. First is this kind of, in the inner part of the ankle, you can see this discoloration and this nest of veins called corona phlebiotectica. And then you can also have hyperpigmentation or change in the color of the skin, usually darkening of the skin, also most of the time in the inside ankle area. This is called Gator's area, and because of the distribution of the great saphenous vein, this tends to be where it's affected. C5 now is a healed venous ulcer in this location. It's shiny, and you can see there's a scar here indicating a previous venous ulcer. Fortunately, it has healed. C6 is the worst kind, where there's an active venous ulcer. It looks angry, red. It may have a lot of exudate, and you can see this would be a problem we want to avoid where possible. So what are the options in treating chronic venous insufficiency disease? So there are conservative options, leg elevation, exercise, compression stockings. There are also different kinds of wraps. We'll go through some of them, and non-elastic garments. So this is a 4-layer bandage. It's quite commonly used to help the venous ulcer, shown over here, heal. It exerts compression of more than 30 millimeters mercury pressure in the ankle region, and that's what's required to heal these ulcers, as well as decrease the swelling and decrease the amount of exudate from the wound. So this can be done usually at the hospital setting. The polyclinics are also starting to do this. It's changed usually once a week, and you can imagine that you have to put a plastic bag in order to shower. Not the most convenient, but it is quite therapeutic. One of the downsides to this would be it is not comfortable. You can imagine looking at this picture, this patient is not particularly pleased, and you can see why. So the other options would be compression stockings. Usually I try not to use the word stockings with my male patients. They don't like to hear that. These are those tight socks that can go to the knee level, the thigh level, or the waist level, depending on the pathology of the disease. For the males, they are those that look like business socks, so you actually can't tell that you're wearing compression socks. There are many brands and varieties available. I'd like to show you what the evidence is and the evidence-based recommendations from ESVS, which is the European Society for Vascular Surgery. So recommendation number 1 is compression of 15 millimeters mercury at the ankle if you have symptomatic chronic venous disease, like I showed you, from C2 onwards. For patients with edema, so we're looking at C3, with changes in the skin color and all that, you need higher compression of 30 millimeters mercury. So you can buy them off the shelf. It's important to make sure that they fit you. That's the most common complaint, is the fitting of these compression socks. Obviously, they are going to be tight and you expect them to be. So it's easiest if you wear them first thing when you get up, when your legs are not so swollen. If you take a shower, make sure you moisturize because they do tend to cause itch, and then put them on. For venous ulceration, in these set of guidelines, again, compression therapy is recommended, and you need even higher pressures, at least 40 millimeters mercury at the ankle. For these, I think you should get specialized medical grade stockings already. They are very tight and sometimes they are 2-layered. Important, as we discussed, we have to have correct compression and then correct size. So there are different kinds of compression that you find on the market. The support pantyhoses, they are usually worn not for compression. They offer a little bit of pressure, but they are not medical grade and don't really offer enough support for chronic venous insufficiency disease. There are compression socks. They're available for purchases at Watson's, pharmacies, etc. online. They offer more support, but you just have to make sure it's the correct amount. And then there are the prescription ones. One of them is shown over here. They tell you exactly, the sizes as well as the compression level. And there are different classes, 1, 2, 3, 4. So this representative prices that you can see in terms of the length of the compression, knee, thigh, waist, and 2 different brands that are just picked randomly. With inflation and everything now, this could have gone up. I haven't checked recently. So this is really the options that are available, but compliance is usually an issue. People find them tight. These compression stockings or socks need to be tight, otherwise they're not effective. And you can have donning aids to help. Sometimes when we have some arthritis in the fingers, it's very difficult to wear these. I've tried them myself, and it does take quite a lot of time and effort to wear them. So these are some aids to wear the compression socks. You can see it reverses it and allows you to more easily wear them. This is helpful for a lot of patients. So we look next at medical therapy, and these are some of the ones that are commonly talked about, and the most common would be Teflon. So I'm going to talk a little bit about Teflon. This is used quite commonly to manage blood vessel problems, sometimes even arterial problems, and it has some benefits like improvement in blood flows and improves the symptoms of varicose vein disease, such as inflammation and pain. And this is a snapshot from Watson's that you can purchase this. They are almost like vitamins for the veins. Now, what about the data for Teflon in chronic venous insufficiency? This is from the Cochrane Library. It's the highest level evidence, and it is discussing phlebotonics, which Teflon flows into for venous insufficiency. So if you look, there are some symptoms like edema or swelling, pain, cramps, heaviness, that it helps improve the symptoms. So these are some things that you can use Teflon for. However, the effect is not uniform. So if you are taking it and it's not really working, I suggest maybe stopping it. The good thing is that there are very few side effects with Teflon. Teflon does not have any benefit in ulcer healing. Remember, I showed you the venous ulcer. If you have venous ulcer, Teflon is not going to help you heal the wound. The one that you should use is pentoxifylline. That needs to be a prescription medication from your medical provider. So third here, I'm going to talk about endovenous thermal ablation. This is in the treatment now. And 2, I'm going to discuss the radiofrequency and laser. This is what most people know about, and they commonly refer to the treatment options as laser veins. So endovenous radiofrequency ablation is delivering energy to the vein, shown over here. In this particular example, every 7 centimeters to heat the vein wall up in order to cause it to collapse. So this is a form of ablation, which means using heat to damage the tissue, in this case, the vein, which makes the scar tissue form. And this scar tissue closes the vein. This is minimally invasive, has been used for many years now, using local anesthesia, can be done using an office procedure. we obviously have to make sure we don't burn the skin. So we usually inject some local anesthesia in this area as well to prevent it from burning the skin. Next, we have more for historical interest, what we used to do, which is open vein surgery. So this is an example of high ligation and division. I hope you are not eating a lunch when I'm showing this. So this over here is an example of an operative specimen of where a leg is prepared in the operating room under general anesthesia. And this is the actual great saphenous vein. So we take it out from this tract in the thigh, in the inside of the thigh, and we take it out using this particular Codman stripper, what we call a Codman stripper. And it is removed. So the recurrence rate is very low, obviously, but you can imagine this is quite a bloody procedure and it's painful. So patients need to stay overnight for this. Fortunately, we do not need to do much of this today. Then there are the newest today, the non-thermal, non-tumescent, which means we do not need heat energy and we do not need to give any kind of local anesthesia around the vein. And there are few options. Let me show you a video about sclerotherapy. This is what I think most people are interested in for the spider veins. So this is a typical spider vein in the knee area, behind the knee. The area is cleaned, and then a small needle, usually a 30 gauge needle, very, very small needle is used. The vein is punctured under direct vision, and you can see injection of a sclerosant, and you can see the vein slowly disappearing. The sclerosant is an irritant to the vein, and it causes the displacement of blood. That's why you see it in this way. While it's very satisfying to show this video and for patients to watch, oftentimes these causes, I'll play it again, these causes quite significant redness in this area, and the veins take a few weeks to disappear. So this is not a procedure where you can undertake 2 hours before you have a special event where you want to wear a mini skirt and expect the vein to disappear. It wouldn't be that. So you've got to expect a 50% improvement or so after roughly 6 weeks. So I think in this case, expectations are very important, and they have to be aligned between the patient and the treating physician. Okay, I'm sorry, I'm told to speak louder, my apologies. Next, we have this example of a non-thermal, non-tumescent treatment option. This is a minimally invasive option, and this one example is a cyanoacrylate closure system. It is just a super glue. Cyanoacrylate is a form of a chemical derivative that uses the chemical bonds to form an irreversible cast. So they have been used in many areas, including the brain, so it's relatively safe. In this form, this is a dispenser gun to dispense the glue throughout the vein where there is reflux. There's no need to deliver heat energy, so there is no risk to the surrounding nerve. As you can imagine, inside the thigh, there are nerves, arteries, veins, and muscles, and the nerve runs sometimes pretty close to the vein, especially below the knee. So there is, it limits the risk for this, and there's no need for compression socks afterwards. So at SGH, we have started doing this since 2016. In 2017, there was a write-up in the Straits Times, and we discussed this option for patients, and we're continuing to do this. We've done more than 2,000 cases so far with good patient satisfaction. So this is a video of what the treatment is about. This is done day surgery inside our minor operating room, and it involves this particular treatment option. There are others also. This is the glue, this adhesive glue, cyanoacrylate I discussed. So under ultrasound, you can see the great saphenous vein is cannulated, and then we can see how close we are to the main deep vein. or the common femoral vein. And then all this under ultrasound will deliver the glue after compressing on the vein in order to shrink it, as well as to not allow the glue to migrate towards the head. This is then delivered in small aliquots, 0.1 cc, so very little glue. And then we compress it in order to allow it to seal. So 3 minutes compression. This is probably the longest part of the procedure, or feels like the longest part of the procedure. And then subsequent to that, every 3 centimeters, we seal the vein. Each 3 centimeters after requires only 30 seconds. So you can calculate if your thigh is about 30 or 40 centimeters, you need just a few minutes to get this done. At the end, we do a completion ultrasound to make sure that the vein is completely sealed. And there's a small puncture site, usually in the knee area, shown over here. A patient gets an adhesive bandage over it and walks home. Activity is allowed during the day. We'll give some pain medication as well as anti-inflammatory medication for this, and it's generally very well tolerated. And patients are able to return to their normal activities pretty soon after. The main complication with this procedure would be phlebitis or an inflammation, and it's important to pick your patients appropriately. So in terms of results, I'll show you, these are the closure rates shown over here. 1, 2, 3 years in the different studies. This is the first in human study, the European study, and the US study. So you can see that the success rates are pretty high in the 90+%. And then at 5 years, it's 93.6%. So this is good. The recurrence rate is low and is pretty minimally invasive. From the patient's viewpoint, this is done under local anesthesia. Most varicose veins, venous insufficiency procedures are now done under local anesthesia, or sometimes needing a short general anesthesia for patient comfort, especially when we remove those large varicose veins. You can imagine when we pull them up using small incisions, it can be quite difficult to tolerate. So again, under 1 hour usually, and then the patient stays for a while for recovery and is able to go home. We encourage patients to walk after the procedure. There is some misconception that after the procedure you cannot walk, which is not true. In this particular treatment option, you do not need compression stockings, which in hot and humid Singapore is very welcome. We also confirm the elimination of reflux but at the end of the procedure, and this is relatively new technology, so patients like it also. This is immediately post-operative. You can see this patient has pretty bad discoloration, and we punctured the vein very low here, treated the entire segment of the vein all the way to the groin area. So this is possible. Second patient is somewhat more typical. The puncture site is here. It is difficult to make out even where the incision was for this. It's a very small, roughly 2.3 millimeters or so. So you can imagine this is very minimally invasive and well tolerated. These are some pictures of representative of pre and post-operative. So not all patients obviously will be the same, but just to get an idea that the veins will decrease in size. And most importantly is actually the relief of the heaviness. So we obviously are concerned about cosmesis, but more concerned about the improvement in the symptomatology and the eradication of the ulcer if it were there. I'll show you a patient video next.
It was just a constant reminder of that something was wrong, and it was very frustrating because I wasn't sure what was going on. Yeah, so my name is Filippa. I'm 30 years old. I have lived in Singapore since 2014. I love being outdoors, exercise, running in particular. I used to go for hikes. That's basically how I spend my free time. I think about 2 years ago, I realized that something was wrong with my leg and I wasn't sure what it was. So the leg was swollen, it was aching a lot, and I had these pins and needles quite often. And close to my ankle, it was like like almost like a spider web. So it was hard to walk. Yeah, just very uncomfortable, like always. So it stopped me from running, and instead I started to walk, but it didn't go away despite that. But I couldn't run, and most of the exercise that I love doing, I had to stop doing that. I did seek treatment quite a few times, both in Sweden and in Singapore, but the doctors told me that it was probably water retention. It was actually it was unbearable after a while, because it prevented me from living the lifestyle I was used to, and I was worried it was something bigger than just water retention. I went to see a doctor who did an ultrasound, and he then referred me to Professor Chong. And then I had a day surgery. All went very smooth. And now I can run again. I'm outdoors more often. I don't have to worry about what I wear. And again, like the pressure on my leg and on my foot especially, it's just gone. So it feels like I can, move like properly again. I'm very grateful for that we could identify that this was a chronic venous insufficiency. Well, I am doing the things that I used to do, which I haven't been doing for 2 years. So I'm running a lot. I'm out going for hikes and spending most of my time outdoors.
So Philippa is an actual patient of mine. I haven't seen her since the post-operative visit, and most of my patients are like that. We don't see them again, which is a good thing, and they're happy with the result. So that's just a patient video.
It was just
and this is the department, 8 of us. All of us do varicose vein treatments. We're happy to offer consults and help in this treatment. Okay, that's the end of my presentation. I will take questions and answers. Before I stop, I would also want to thank our SGH Patient Liaison Service, as well as the Medtronic team for organizing this webinar. Okay, I'm going to look at the Q&A now. Okay, first question is related to cost. So cost of various treatments vary depending on your subsidy level, for example, whether you need to have general anesthesia or local anesthesia, whether you do one leg or both legs, and whether you need the varicose veins removed, what we call phlebectomy. So it's really difficult to give a figure for this, but definitely if you come in for a consult or email the PLS team, they can try to give you that estimate. MediSave does pay for these procedures because it's a medical procedure and not a cosmetic procedure. Second question is about massage, whether it can help with varicose veins. Massage has many benefits, and it helps relax the muscles, helps with our stressful lives. It doesn't help particularly with varicose veins, except that when you're lying flat, the pressure in the varicose veins would be much lower because you're lying flat. So it doesn't help varicose veins, but doesn't hurt it. So even with varicose veins, you can have massage. And post varicose veins treatment, also you can go back to your massage. Next question is coming from a patient who has lipodermal sclerosis or color discoloration, and the valves in the calves are not working. So is this the same as varicose veins? Varicose veins are what we actually see, what we can see underneath the skin, those large veins that we can see. So if you have those, then you have varicose veins, but the likely reason for this is because of the malfunctioning valves or the chronic venous reflux that I showed earlier with the physiology video. And then the lipodermatosclerosis is the color change in the skin, as well as the thickening of the skin and hardening of the skin, usually around the ankle area in the inside of the thigh, that may be related to the varicose veins and the venous insufficiency issue as well. So if you have this and it's affecting you and you have heaviness, it's probably something that you should get looked at. At the least, you need to be considering compression stockings, and there may be more that medical therapy can help you with. Next is, can I leave varicose veins in my legs? Yes. So varicose veins are not going to be life-threatening. So this is not an emergency. No emergency at all. You're not going to lose your leg. So that's something that I always tell my patients. If you have no pain from it, other than being unsightly, you can leave it. So not all varicose veins need treatment. However, if they cause you some discomfort, heaviness, aches, you have ulcers, discoloration, you might want to consider treating it before it becomes a bigger problem. But if you are totally asymptomatic, it doesn't cause you any problem, then you can leave it alone. Yes, definitely. Okay, next question. You can get treatment. So most of the treatment are going to be minimally invasive. I'm not very familiar with this particular medication. However, there are very few medications that will be contraindicated with the treatment of varicose veins, especially it's an outpatient procedure, it's minimally invasive, and shouldn't give many side effects. So this is something you should discuss with your healthcare provider. Next question. Okay, movement of the legs with the toes up and down. This helps activate the calf muscle pump. So the muscles in your calf, namely the gastrocnemius and the soleus muscles, they will be activated. So it does help. You can help when you do that, it moves the blood back towards the heart. Even if you cannot walk around, it's good to activate those calf muscles. So it's a good idea to do that even when you're sitting. So you might be doing your Zoom session or something like that, or your team meeting, and then you can still do this. Nobody needs to know. Okay, next question. Reasons that females are more prone to varicose veins. So nobody knows 100% why. There may be some hormonal changes that explain why the valves tend to be more leaky. It is known that estrogen, for example, has an effect on these. For women that have had children, carrying a fetus for 9 months in the belly, increasing the blood volume, having elevated venous pressure during pregnancy period could contribute to this as well. But we don't know exactly why that's the case. But both males and females do have venous insufficiency, and it affects both genders. So it's not a problem only for females or only for males. Okay, next question. At what stage should you go for treatment? Okay, I think what it would be obvious would be if you have a venous ulcer, it's very clear you need treatment for that. Hopefully, obviously, most of our patients don't come with that. And then in terms of what to consider next will be the symptoms that you have. So if you have a lot of swelling, if you have heaviness, if you feel at the end of the day you really are dying to put your legs up, these could be symptoms where you could benefit from treating varicose veins and venous insufficiency. So this is where you think about treatment. If you don't have any complaints, you don't have to have treatment at all. Yes. And one of the ways where you can try to determine for yourself whether or not treatment would help in terms of varicose vein treatments would be wearing compression socks. If wearing compression does help you, makes your legs feel lighter, then this is likely a venous insufficiency problem. Next question. You can do a jab and disperse the vein. So I think this is one of the earlier videos I showed about injection sclerotherapy, where you're injecting into a spider vein and then the vein slowly dissipates. The vein actually doesn't disappear, but the sclerosant that you inject into the vein causes the blood to be displaced, and that's why you don't see the vein anymore, even though it's still there. And because it's a sclerosant, so it's a special chemical that irritates the vein wall and causes it to collapse. So this can be done usually for smaller size veins. So for large veins, for venous reflux, those kind of size veins, probably not as effective, although can be done also. The risk for those is how do you prevent them from going to the other veins where you don't want the sclerosant in, for example, the deep veins or the larger veins. Next question. Varicose veins during pregnancy is a very common problem. I would say it's almost normal. You should not do anything during pregnancy or in the immediate postpartum period, including the breastfeeding period. First of all, at this age, you're very young. There's nothing that you need to do, and having a baby is a lot of work, and there's a lot of care that you require to give to the infant. So this should not be the concern during the pregnancy period or the postpartum period. It needs to be after that where you consider treating varicose veins. So during pregnancy, I would say ignore your varicose veins. It would be a good idea to wear pregnancy support hosiery. There are those that are made for the pregnant women, and you can consider getting this during pregnancy. Next question. Spider veins get worse over time. So unfortunately, as we age, a lot of things don't go as well. And we tend to get more spider veins. That's a reality. They don't tend to disappear. So if it's cosmetic, then in general, MOH considers this a cosmetic problem, and Medisave will not be able to pay for this. This is MOH's stance on this. Yes. Next question. So leg elevation does help with chronic venous insufficiency and venous reflux problems, and often you feel lighter. Soreness in the legs. So leg elevation is not good. It's good for venous disease, but not good for arterial disease. So if you have problems getting the blood flow to the toes, then lifting it up will have even less blood flow, and this may be this problem. Otherwise, lifting your leg up could be stretching the nerves in the back, and this could be causing some kind of tension in that area, and you could feel soreness as well. So depending on the problem, this could be another issue not related to the veins in your legs. Okay, next question. Surrounding tissue be damaged or killed after veins are closed off. So it depends on which treatment. In the venous ablation with thermal energy, whether it's laser or radio frequency, you deliver energy into the vein area, and the surrounding vein will be charged. The heat will obviously dissipate into the surrounding tissue. So there'll be a little bit of damage to the surrounding area. That's why we give what's called tumescent, which is local anesthesia solution around it. So it acts as a heat sink, and it doesn't allow for the skin, for example, and the nerves to be damaged. If you do an intraluminal therapy, for example, the super glue, like I mentioned, then it doesn't go out to the outside. So it shouldn't have any effect on the surrounding tissues. Yeah. Next question. What types of patients are more prone to varicose veins? So if you can, you should choose your parents. So genetics are very important. And some people just come from a long line of aunts, uncles, parents, both with varicose veins, then you are very likely to have varicose veins. So genetics are important. Then it would be long-standing. So occupations that require long-standing would always have more chances of patients developing varicose veins. If you lie down all day long, if you hang upside down like a bat, then you are not going to get varicose veins. And then maybe wearing compression stockings would help prevent varicose veins as well, or maintain your legs so that varicose veins don't happen. So patients who are larger, obese, for example, have more pressure in the pelvis, so the venous return is more hampered, and these could lead to higher venous pressure, resulting in more chances of developing varicose veins. So these are probably the kinds of patients that would have varicose veins. Next. So operation to remove varicose veins, they're not designed to help you walk better. That's different. The varicose vein operation is designed to stop the venous reflux, so there's no more venous reflux. As a side effect to that, maybe the leg heaviness could go away. As a result, patients can walk better. However, that's not the main purpose of the varicose vein or the venous insufficiency treatment. It would be to get rid of the venous reflux, to decrease venous pressure in the ankle area. And all the symptoms could get better, but it's difficult to predict in whom the patients get better. We obviously hope so, but it's not always the case. Next question. It's great that we have a lot of questions. We have 60 questions, I see, or more. For the glue, would the vein have blood flow? So that particular vein, which is the great saphenous vein, most often, after it's treated, it would no longer have any blood flow in it. Because the vein was faulty or defective to start with, because the blood flow is in the wrong direction, the blood would then flow into the other veins, the deep veins, for example, that would return the blood back to the heart. So this has to happen, otherwise your leg will swell really, really big. Next. So no visible sign of varicose veins, but cramps in the feet. Okay, so cramps unfortunately affect a lot of us, and we can get it in the feet, in the calf, in the thigh, buttocks. It can happen at any time. It can be due to a variety of causes, and it may not just be varicose veins. Certain electrolyte imbalances, for example, lacking potassium, also causes cramps. So it's not just varicose veins that causes cramps. It's difficult to say for everybody whether this would be a sign or symptom of varicose vein disease. Next question. I think we talked about this before. Prevention of varicose vein, there's no good prevention except for wearing compression and then minimizing time of prolonged standing. Next question. Does the glue dissolve? So this is a permanent bond that is created after the glue hardens up. So it does not dissolve. It remains in the vein. The glue may get softer. So in some patients, they can actually feel it, especially if they're very slim, but it tends to get softer over time, but it does not dissolve. This is a permanent remnant in the vein. It is non-allergenic, hopefully, and it doesn't have any cells in it, so shouldn't provoke too much of a reaction. Next. What kind of exercise can... there is no restriction of exercise before intervention. There is no restriction of exercise, usually 2 weeks out, nothing. In the immediate post-operative period, I often advise my patients to walk as usual, to go buy food, do their groceries, do whatever they need to do on a daily basis, but avoid signing up for a marathon, doing a 10-kilometer walk for leisure, that kind of stuff. But normal activities are okay, even immediately post-operative. Next. Spider veins above the knee, are they critical? Most of the times, in general, spider veins are not critical. They tend to be cosmetic. They tend to occur around a ring in the upper thigh area. That's one of the common areas of having spider veins. So they're not critical. No, not at all. Next. So there is no cutoff for treating venous disease. The older the patient is, we obviously have to weigh the risks and the benefits of the treatment. For any age group, we've heard this before, it's just a number. Some 60-year-old patients are, really not in good state of health, versus some 80-year-olds are very spry nowadays. They don't look their age and they're doing a lot of things. So we have to take all of these into consideration before offering treatment. And we always give patients the option of a conservative treatment versus invasive treatment if it's suitable, if the ultrasound shows reflux, that kind of stuff. Next question. The glue treatment is for the venous reflux in the great saphenous vein, the vein in the thigh, is not for spider veins. Spider veins are not suitable for the glue treatment. Next. So for patients with venous insufficiency, does this affect the quality of blood vessels available for potential heart bypass? Okay, yes. So that's a very good question. So heart bypass usually requires a venous conduit, so a vein to graft on to the coronary vessel. And traditionally, we have used the great saphenous vein in the thigh or in the lower leg. So if we treated it already for venous insufficiency, then we cannot use it. However, it is a faulty or defective piece of vein. So I'm not sure if the cardiac surgeon also wants to use these kind of veins because it's dilated and it may not be the best for the bypass. They can consider using other options, for example, radial artery or the internal memory artery as a conduit for these. So it's great to see that all of you are giving a lot of questions. Now we're 77 questions, so there's a lot of interest in this. Thank you for submitting the questions. I don't think we have that much time left, so we'll try to get one or two more. Okay, next question. Is it good to remove spider veins? So spider veins and varicose veins are different, and it may not be a continuum. They may not progress to varicose veins. I would say most spider veins don't progress to varicose veins. So I don't think it's a big concern yet. So mainly we have to look at the symptoms of heaviness and whatnot before we think about either investigations or treatment options. Next. Age limit, I think we discussed that there is no age limit for this. Okay, it's 158. This is the last one question. C1, C2, C3 disease. Okay, right. Yes, it doesn't mean that you have to start with C1 and then slowly progress along the chain. Some people first present with the venous ulcer, C6 disease, and it's really difficult to predict. This C1 to C6 is just a way for us to pigeonhole patients into different severities of disease and give us guidelines onto what kind of treatments and treatment options we should offer patients. So that's a very good question. I'm sorry I'm not able to get to all your questions, but time is running out, and I'm sure that you all have other things to do this afternoon. I'd like to thank you all for attending this, and I think you got an email as well. You can keep those questions coming. Otherwise, good luck with your veins. Bye-bye.